So we'll discuss about ovarian cancer. In this following lecture, we'll discuss first the risk factors, then the types of ovarian cancer, benign and malignant, then histopathological classification of the ovarian cancer, the epithelial, germ cell, and the sex cord. Then we will go towards the management. In the management, we'll study the staging, the treatment part, and in the last, we will discuss some case-based scenarios. Coming to the risk factors are the high estrogen states, as similar to the endometrial cancer, as discussed in the previous videos. These risk factors are nulliparity, early menarche, late menopause, obesity, PCOS, HNPPC, Lynch syndrome, BRCA1 and BRCA2 gene mutation. The protective factors are reverse of it, like multiparity, OCP use, tubal ligation, hysterectomy. Coming to the types are benign and malignant. The benign one is usually has a long history. The mass is painful. It's unilateral. It's cystic and soft. Whereas the malignant one has a short history. It's seen in the postmenopausal age. It's usually bilateral but painless and non-tender and solid and firm lesion is seen. Coming to the transvaginal ultrasound findings, the benign one is usually an echoic unilocular, whereas the malignant one is multilocular. It has a papillary projection also, and you can also see the vascularity on the Doppler. And the size of the malignant one is usually greater in size. Coming to the types based on the histopathological examination. It is classified into epithelial, germ cells, and sex cord. The epithelial one has a worst prognosis. Coming to the on the basis of age, the epithelial one is seen in the postmenopausal age, whereas the sex cord can be seen in any age, mostly seen in the perimenopausal age, and the germ cell is seen in the young age. The epithelial one is usually bilateral, whereas the other two are unilateral. Epithelial one has a worst prognosis. Coming to the tumor markers, the epithelial cell has tumor marker CA125, CEA, whereas the germ cell has a tumor marker of LDH alpha fetoprotein, and the sex cord tumor has a tumor marker inhibin B. Coming to the further classification, the epithelial one is classified into mucinous, endometrioid, clear cell, Brenner cell. In this, you just remember that mucinous one is also associated with pseudomyxoma peritonei. The endometrioid and clear cell are associated with endometriosis, and the Brenner cell is associated with coffee bean nucleus. The bladder epithelium is seen in the Brenner cell tumor. Coming to the germ cell, there you will read about dysgerminoma, dermoid. In dermoid, you will see Rokitansky protuberance on USG. Coming to the sex cord tumors, it is further classified into granulosa cell tumor, fibroma. The granulosa cell tumor, you will find Karl-Exner bodies, coffee bean nucleus, and whereas the fibroma, you will read about Meek syndrome and pseudo-Meek syndrome. It is usually it consists of granulosa cell tumor, thicoma, Brenner cell. These all tumors, along with pleural effusion and ascites. This is Meek syndrome. When any other tumor apart from these sex cord tumors is there, then it's called pseudo-Meek syndrome. Now coming to the staging. Staging is classified into stage 1, 2, 3, 4. One can be further classified into 1A, 1B, 1C. 1A is unilateral ovary, 1B is bilateral ovary, 1C is intracapsular rupture, 1C2 is already the capsule has ruptured, 1C3 is malignant ascites. Stage 2 is when it has spread to other pelvic organs. The stage 3 is when it has spread to extraperitoneal space. And the stage 4 is when it has malignant pleural effusion or distant metastasis, like parenchyma of the abdominal organs and inguinal lymph nodes is involved. Coming to the surgery, stage 1 and 2, stage 3 and 4. In the stage 3 and 4, we do the debulking surgery, and we also use along with it chemotherapy. So this was all about ovarian cancer.